Read it out loud again.
So, Chronic Fatigue Advisory Committee recommend to the Secretary that he recognise special challenges of ensuring chronic fatigue syndrome is part of any efforts to train or educate providers under healthcare reform.
Can you help us maybe also understand what are some of the implications of that? Just, I mean, how that might translate. I'm just wondering if either of you might give us your thoughts.
My thought is that once you get it recognized at that level, it starts to move up the priority list for everybody else. And I'm not sure how it works in government, but my perception is that when people recognize something, it's almost like saying, you know, go and do it. I mean, we have university priorities. And when people list the priorities, all of a sudden everybody starts making those their own priorities because that's where the money follows. So I may be reading more into it, but
the health reform bill, as you know, is well over 2,000 pages and contains in many places opportunities for education of health providers. Much of it is focused on recruitment and the pipeline into nursing, social work, physical therapy, all of the associated health disciplines, not just medicine. Includes some doctoral training as well, and efforts, in fact, to recognize that the healthcare workforce to really step up and to realize the promise of health reform has to be a high-performing workforce. In very, very broad language, in many different chunks of that bill. My sense is by simply getting from this advisory committee, as you've just voted, a recommendation that, you know, chronic fatigue syndrome be considered in however any of those efforts play out, that it would seem to me to be, you know, a no-brainer, if you will. How it plays out, whether it means money eventually, you know, frankly, we don't even know what dollar signs are being attributed to many parts of health reform that are very clearly, some have been appropriated, some are directed but not appropriated, and many are still to come online. So, you know, I think getting chronic fatigue syndrome queued up in the broad health reform arena, I don't think you're going to have a better time to do that than now. Any
way of us kind of, in a sense, getting feedback or monitoring or getting some sense of, maybe through Christopher's conversations with yourself and Dr. Coe, about how things might actually develop along with this recommendation in terms of consequences?
I think absolutely. Obviously, it's a recommendation that all the ex officios would be looking at, and parts of the department that are not currently engaged here in this forum, because, I mean, believe me, all of us in our free time and every other hour of the day for 32 hours a day are being directed into the health reform efforts because the agenda is so aggressive and so broad.
It gives us the opportunity to continuing asking questions that anywhere that health reform touches, that's opens a door for us to put ourselves into the picture.
This really comes back, I guess, to, again, I think the issue that we started with Nancy suggested, and that is, and Galen and others here have said again and again, that there's literally thousands and thousands of people in this country who are, in a sense, out of the system, whose needs are not being met. You know, I might add that one of our members here kind of said that it was only through public testimony of hearing the patients comment about the types of restrictions on their lives and the lack of resources for them to get help, that person stayed committed to this field and decided to stay with it, because there are barriers that we all know. So again, it just comes back to that issue of that need. The need is unmet, and the need is stark, and there's thousands of people who are not getting their needs met in our healthcare system because they have this illness.
And I think that's a good, legitimate argument for the Undersecretary to do this, that we have the demographics, we have the numbers. Do we want to make an early start on the charter and start to look at that? Or have we got some business to finish off on how we deal with the recommendations? Nancy and then Jason.
I think that we haven't really gone through the recommendations. If we are going to break into our subcommittees, something the subcommittees might do over lunch is see which of these older or more current are still valid, and maybe in their subcommittee statements say which ones they would prioritize. There's one rather pressing one that's very old in here, but has not come back up. But now it's a big deal. Is the ICD-9 codes going back into a psychiatric ICD-9 code? That's a huge deal for our patients, not a small deal, and it looks like it's going to go down that path. And I think that we have to not let that slip our sights right now, because the timing is key. You can't wait for the next meeting to deal with that issue.
Jason.
Well, I want to echo that in part. If we can talk about the charter, and then for lunch talk about recommendations sort of collectively and come back with more insight, because I don't know if we all spent the time focusing on it, and the new members can get better insight from discussions with those that have been here for a number of years. That would be what I would recommend.
Trying to think of a mechanism that we could prioritize that we didn't have to do it verbally. So maybe the subcommittees can rank recommendations 1 through 5, and we see what we come back with, what we have when we get back together.
As you might have noticed, it's even though I developed a chart, I find it, I'm looking at it like I never saw it before. It's like, what? Because I guess it's just one of those days. But they are somewhat organized into research, education and training, and care and services, and then some CFSAC specific issues that were brought up. And as Nancy pointed out, that ICD code sort of hangs out there and is even flagged yellow. The science of CFS doesn't support this action at this time, but revisiting, that's 3A904 on page 10 of the recommendations document, and I thought it did appear in another part as well. But regardless, we tried to cluster these at least somewhat loosely by the subcommittees to try to focus subcommittee efforts and time. But that doesn't mean that there aren't pieces. There are many education pieces that are buried in some of the research components, for example, and some clinical care pieces that are sort of buried there, but they were made as part of a recommendation we had to put somewhere. It was primarily research. Okay.
So if the subcommittees could do that over lunch and then come back to the larger group with some points of discussion on some of these, we should be able to clarify.
I've had some private discussions, probably with 1 or 2 committee members, talking about thinking what committees we want to survive or continue and thrive. And the Patient Care Quality of Life Committee that I've been on, and we had Rebecca Artman and yourself. You're not there at this point because you have other responsibilities. I'm rolling off, so we probably should talk about the continuation of that committee, continuity for that committee, whether we want to actually have it continue or put our resources more into some of the others, and I think that should be part of our charter discussion.
And if I didn't mention, Stephen Krafchick will be filling in behind you. He's already been through the process and will be sworn in just as your term is expiring, Jason. We do have Mr. Krafchick here to be part of what's going on in this meeting, so he's not left in a vacuum rolling forward to the fall meeting, which otherwise would have been his first. So we're very grateful he was able to be with us today in an unofficial capacity, but we do look forward to his service beginning in July.